Thank you, Mr. Chairman, who is, I think, going to sleep because it is an American time, and Dr. Khanna and the organizers. Now, we have already listened to various success stories regarding management of abdominal aortic aneurysm by the EVAR procedure in the last 2 decades. And even for that reason, in United Kingdom, 70% of our procedures are done by endoluminally today. But with every success, there comes some problems, and that's what I'm going to discuss in the next 10 minutes. One of the problems that we all face is the endo leak, and we already know how we can deal with the type 1, A, B, or type 3 endo leaks. But type 2 is the endo leak, which is the most controversial, and this is what we have been discussing almost in every meeting today. I will mostly dwell on the discussion regarding the management of type 2 endo leak, as there is no problem, as we already know the answer to type 1 and type 3 endo leaks. Now, the way the type 2 endo leaks are described is that either it is due to single or multiple feeding vessels, and sometimes, therefore, it is described as if it is an arteriovenous malformation with multiple feeding vessels. And then whether it could be primary, that appearing within 30 days of the EVAR procedure, or it is secondary, or it is just present transiently and disappears within 6 months, but it may remain persistent in the later during the surveillance. There are various ways of detecting type 2 endo leak, the commonest being the duplex ultrasound, which is used as part of our surveillance program. What is being more commonly used nowadays is the contrast-enhanced ultrasound scan, although the recent paper from St. George's in the UK suggests that it is probably better for type 1 and type 3, but not for type 2. But what has been more interesting nowadays is the volume estimation by 3D ultrasound, which is becoming, probably in the future, it will become the norm to use this modality as the method of surveillance procedure, as well as pressure management in the sac by different ways. But having said that, the standard traditional way of identifying the endo leak is the dynamic CTA at the release phase, and as well as that also MR angiography. This is just a description of the 3-dimensional ultrasound volume measurement of the sac, and which gives better idea about the sac expansion than the standard diameter measurement. As I said, the MRI is probably more sensitive than CT angiogram, and as you can see the figure here, but they are quite commonly used in our routine practice. But there are problems with regard to the type of metal that is being used in your stent graft, as stainless steel will not be compatible for MRI scanning. We also have shown a lot of interest recently about computational fluid dynamics to assess the stress level and the change in stress level due to type 2 endo leak, and whether it will guide us in future, whether we need to treat this endo leak or we can just leave them alone. So, how should we treat type 2 endo leak? Should we always treat them, or should we wait, or should we preemptive strike them? There are many things that we have learned from the natural history of type 2 endo leaks. And one such paper which suggests that the 8-year experience of type 2 endo leaks, that only selective intervention is necessary. In another study, it showed that rate of spontaneous closure of type 2 endo leaks occurs in about 75% of the time when these patients were followed up over 6 years. Similarly, if you look at the freedom from aneurysm enlargement more than 5 millimeter, it was also possible to see that only few patients do enlarge their aneurysm sac after 5 years due to type 2 endo leak. So in other words, almost 75% of the aneurysm endo leak usually close at the end of 5 years or so. And in another study, there was no aneurysmal rupture, which is a large review of 10 trials comprising of about over 2,000 patients. Similar results also available in other literature. But this is the other part of the story where the people are more scared, or the opposite side views that there is also association of graft ruptures And particularly after EVAR procedures, 10-year EVAR procedure, we showed that 9 graft rupture because of the type 2 endoleak. And there is a higher rate of rupture, higher rate of second enlargement, and higher reintervention rate and conversion to open repair. Another study, in the Eurostar study particularly, there was 9 ruptures, although most of it they thought that is due to persistent type 1 endoleak. But that is a cause for concern even with type 2 endoleak in these patients. So how do we treat these patients with type 2 endoleak? Most common procedure that is being treated, this problem is treated, is by translumbar sac puncture. All of the procedure, particularly the endoluminal angiographic procedure of closure of the endoleak, is not very successful. Some people have tried transcaval sac puncture, and our group also have tried to ligate the inframagentic artery by laparoscopic ligation, and there are also other ways, extreme of dealing with this problem. Various things have been used: coils, glue, thrombin, onyx, gel foam, and so on. But one has to remain careful, particularly in the use of thrombin and glue. It might reflux into the spinal arteries and can cause paraplegia or hemiplegia. This treatment does not come without any complications. They need second attempt, third attempt to close the endoleak. They need long-term follow-up. There can be accidental puncture of the strain graft causing type 3 endoleak. There may be colonic ischemia, and the complication rate could be as high as 8.6%. Some people gone to do the secondary procedures and have found the success rate is only 34%. In other words, about 2/3 of these patients where we try to close the endoleak and we are not successful. There is a problem there. So therefore, some people, although they know that the success rate of closure of the endoleak is not very good, but some people have thought of preemptive strike by closing the type 2 endoleak, by closing the IMA or lumbar vessels, whichever is present or whichever is dominant, despite knowing that 75% of these patients may close spontaneously. The problem is that these procedures do not come cheap. They cost nearly $7,000 for each procedure, and it may multiply with subsequent procedures. And secondly, the complication rate for these procedures is also quite high. So what are the predictors of persistent endoleak so that we can selectively identify which patient needs to be treated or which patient needs to be continued under surveillance? If there is a large patent IMA, inframagentic artery, the size of the IMA, or more than 2 lumbar arteries, and some studies have shown that if there is higher systolic blood pressure, mean pressure of more than 148 millimeter mercury, and hyperlipidemia, these are the risk factors for persistent type 2 endoleak. This is just one example of one predictor of continuous or persistence of type 2 endoleak is the nidus. The nidus, that means that is the contrast in the aneurysm sac. If it is more than 2.3 centimeter, it is more likely to remain patent, and that might need treatment. Similarly, if the thrombus, which occupies the aneurysm sac, is in a higher percentage than the lumen, then there is a high risk of endoleak, type 2 endoleak. As I said, number of patent aortic side branches, patent IMA, all these are again important predictors of persistence of endoleak. So therefore, I think what we need to do, as we saw that many of these patients do close their endoleak in surveillance, in practice, so we need to introduce what is called surveillance for the type 2 endoleak, and what we need to look at is the volume changes and the pressure changes within the sac. And this is my final slide, which has been published in the Journal of Endovascular Surgery by Lawrence Brown from Australia, which says how we should follow these patients and when should we do the pressure management, when the volume measurement of the sac, and how should we intervene in these patients. Thank you.
Thank you very much indeed.
Very much, Dr. Saroj Das. I was just thinking, I mean, if you think, I mean, there is a lot of, most of these would close by themselves, is there a real need to worry before the procedure of coiling the internal iliacs, or sometimes even coiling when we are in a suspicion whether the patient is going to tolerate, we coil both. We can easily leave one and then see how it goes, one of the internal iliacs, especially in old patients.
That's the beauty of coiling them is that you can stage them and space it out over time, rather than covered at the time of the same procedure.
So what would be your strategy? Do you have a patient of like 80, 90 years old and you want to, the aneurysm is extending all the way to iliac bifurcations on both sides? Would you cover both, or you would leave one and not worry about the endoleak and see how it goes?
I think we will still pursue a conservative treatment in these patients unless the sac is enlarging more than 5 millimeters, or the pressure within the sac is rising. Definitely we will repair it.
And how would we sort of, except for a CT evaluation or an echo evaluation that the sac is increasing in size, is there any other way we can sort of diagnose endotension, type 5 endoleak?
That is the pressure management within the sac. That is actually.
So, I mean, putting in transducers there?
Transducer, well, if you can put a silicon chips within the aneurysm sac and an external transducer, you can measure the pressure of the sac. And that can guide you whether the sac is expanding or the tension is rising within the sac or not. And of course, before that, whether it is a type 5 endoleak or whether it is a type 2 endoleak, depending upon there is a leak from this IMA or the lumbar vessels.
So are these transducers available commercially? I mean, I know that Takoki was using them experimentally, but I don't know whether they are commercially available.
What's that?
The transducers for diagnosing endoleaks, endotension.
Yes, there were people that put them in, and they were put in for a while as an investigation, and then actually became FDA approved and compensated for. But the problem is their reliability began to be questioned, because once if they're in thrombus, they may not transmit the pressure exactly the same way. If they're, for example, you put it in an aneurysm sac where you have an endologix graft, but the fabric is not attached to the frame. And so the transducer is here, the fabric is moving back and forth with each pulsation. It transmits that pulsation out to that transducer, even though there's no leak or no anything. So basically, the company, I don't think, markets them anymore for implantation for aneurysm. Where they're being used, the device has been modified, and it's being used as an implant in the pulmonary artery for management of chronic heart failure. And people will have that in there, they have the chip in, and then when their pressure, pulmonary artery pressure goes up, they get instructions from a physician or a physician advanced practice person. Take Lasix for, if it gets to this, you increase your diuretic dose. And it's to cut down return visits to the ERs. And that has been quite successful in some trials where they've done it.
And that's put percutaneously?
Yeah, it's put in percutaneously, yeah. That's good. Yeah. It's a very small device.
And I think the other way to tackle this would be to put in devices which fill up the sac. I mean, that would prevent type 2 endoleaks.
We'll talk about that.
Yeah, there's the next
I
topic.
think the Nelix device,
Right.
like closing the aneurysm sac, probably remains the.
Yeah,
Yeah,
I've got a
Dr.
talk
Buckley's
on
gonna talk
Nelix,
about it in the
and
next
I'll
session.
tell you, I think that's one of the most exciting things that's come down the pike here for the treatment of aneurysm disease in the last few years. I think it'll really, I truly believe, from all I know about the device, that it will probably revolutionize the treatment of aneurysm disease. First of all, it's simple to apply, and second, it really eliminates all of the neck angulation and other requirements that we've had. But I've got to talk on it a little bit. One thing I want to mention is the business of if you have aneurysms in the iliac coming down to the iliac bifurcation, as long as you're at about 25 millimeters or a little bit or smaller than that, you can bell bottom the graft. There are grafts now that have actually a bell bottom into them that comes right down to a wide common iliac. And people say, well, you're putting this into aneurysmally diseased vessel, or you're putting it into thrombus at that area. And that is true, and everyone has wondered whether that's going to hold up or not. We have a series of about 86 iliac artery aneurysms. We have a lot more than that, but in this group of iliac artery aneurysms that were associated with abdominal aneurysms, we have 85 or 86 patients that we bell-bottomed one limb into an iliac aneurysm. Sometimes it was both limbs, both sides. And I went back and looked at that not too long ago, and we have of the patients that we have 5-year follow-up on, which is almost all of those 85 patients, we have only had to go back on 3 occasions because of a type 1B endoleak. Only 3 out of 85
Yeah,
resets.
I think that story, yes.
And so I don't hesitate to do that because I look at people, you know, most of the people we're treating are in their late 70s or 80s, and most of them have other things wrong with them. And so I think it's a good, I think rather than coiling, the problem with coiling the hypogastric is that almost half of them or more get buttock claudication. And you know, you can save somebody's life from a ruptured aneurysm, and you come in with that, and you coil out hypogastric at the time you're there. Every time they come in the office, they'll say, you know, and my bottom still hurts when I walk, doctor. When is that going to go away? And I tell you, so I tend not to coil if I can avoid it. And we've bell-bottomed, I think, 3, we've had to intervene on 3 out of 86. And that's over more than 5 years of follow-up on all those patients. I think that's pretty durable. And I heard Frank Criado say something similar to that not too long ago, that he felt it was still a pretty durable thing to do, too.
Thank you very much.
Thank you very much indeed.